Welcome, everyone. We're going to jump right into the updated 2025 Hungarian guidelines for HER2-positive breast cancer. And let me tell you, these aren't just minor adjustments. We're talking about some really significant, practice-changing shifts in our treatment algorithms. So let's get straight to what you need to know for your clinic.
We're going to follow the patient's journey, basically, starting with the foundational classifications, moving into early stage strategies, then what to do after surgery, and finally, we'll cover the new sequences for metastatic disease and the tricky issue of brain metastases. Okay, first things first. The entire treatment framework, everything we're about to discuss, really hinges on one crucial distinction we have to make right at the start. Right out of the gate, we have two very different paths. Every single HER2-positive tumor has to be classified as either non-luminal or luminal B. Now, for your luminal B patients, the guidelines are crystal clear. You must add endocrine therapy, usually an aromatase inhibitor, right alongside the anti-HER2 backbone. It's a simple fork in the road, but it has huge implications for treatment. Now, let's talk about early-stage breast cancer. The new guidelines have really cemented the neoadjuvant first model. This is now the standard of care for most of our patients. The guidance is really direct here. If a tumor is over 2 centimeters, or if you've got any node-positive disease, we go straight to neoadjuvant therapy. And the preferred regimen is TCHP. That's docetaxel, carboplatin, trastuzumab, and pertuzumab. The beauty of this anthracycline-free combo is that it maximizes our efficacy while, importantly, minimizing that cardiotoxicity before the patient even gets to the operating room. But, one size never fits all in oncology. For a very specific low-risk group, we're talking small, PT1B, node-negative tumors, we have a clear option to de-escalate. We can use a less intensive regimen of Paclitaxel plus Trastuzumab and spare those patients some unnecessary toxicity. So this brings us to a really pivotal moment. The patient has had neoadjuvant therapy, they've had their surgery, and now that pathology report is going to be our roadmap for everything that comes next. And this is the million-dollar question, isn't it? Did the patient achieve a pathological complete response? The answer, yes or no, determines our entire adjuvant strategy from this point forward. If the answer is yes, if there is no residual invasive tumor, well, that's fantastic news. The path is simple and clear. The patient just continues with their dual HER2 blockade to complete a full year of therapy. This is obviously a great prognostic sign. But if there is residual invasive disease left behind, the guidelines are definitive. We must escalate therapy. The standard of care now is to switch the patient over to the antibody-drug conjugate T-DM1, or Trastuzumab Emtansine, for 14 cycles. And this change is directly driven by some landmark data. The recommendation to switch to T-DM1 is based entirely on the incredibly powerful results from the KATHERINE trial, which showed a major improvement in invasive disease-free survival for these higher-risk patients. Okay, let's shift gears and move into the metastatic setting. Because here, the guidelines have totally redefined the standard treatment sequence, especially when we get to the second line. In fact, the guidelines don't hold back at all. They describe this change in second-line therapy as nothing less than a paradigm shift in how we manage metastatic HER2-positive disease. And that's not a term we throw around lightly. So here it is, the new treatment ladder. First line, that stays the same, a taxane with dual blockade. But look at the second line. That's the major change. Trastuzumab Deruxtecan, or T-DXd, is now our preferred agent, effectively pushing other great options, like the Tucatinib combination, into later lines of therapy. So let's be absolutely clear on this point. T-DXd has officially displaced T-DM1 as the second-line standard. This is based on the head-to-head DESTINY-Breast3 trial, which showed superior survival data. This is a change we all need to integrate into our practice right away. And finally, let's talk about a scenario that we all face and find incredibly challenging: the management of brain metastases in this patient population. The approach here is really all about disease activity. If you have active or progressing CNS lesions, you have to prioritize therapies that we know can get into the brain. That means T-DXd or the Tucatinib combination. On the other hand, if the brain mets have been treated and are stable, you can just continue with whatever systemic therapy is working for their disease outside the brain. So, to wrap it all up, here are the 5 big takeaways from the 2025 guidelines. First, always classify your tumors by hormone receptor status. Second, use TCHP as your go-to neoadjuvant regimen. Third,
If there's residual disease, you pivot to TDM1. Fourth, in the metastatic setting, T-DXd is your new second-line standard. And finally, for active brain mets, think T-DXd or the Tucatinib regimen.
And this all leads us to a really fascinating question for the future, doesn't it? With these incredibly powerful ADCs like TDM1 and T-DXd moving so much earlier in the treatment course, it makes you wonder, what are the third, fourth, and even fifth lines of therapy going to look like for patients who progress on these agents? That right there is the next frontier we're all going to have to figure out together. Thank you for your time.